Hello my dear students, today we are going to study about intestinal disorder. That is, one of the intestinal disorder is an abdominal hernia. Okay, so let us understand what is abdominal hernia. Hernia is nothing but a protrusion which is coming out, or there is a push of either of the organs of the abdomen which are coming out, which are protruding outside or which are being pushed outside. Okay, and it can be seen as a bulging on the abdominal surface. Okay, and the simple word is nothing but, you can see in the picture how there is an umbilical hernia. Okay, so the organ or the tissue of the abdomen, they are being pushed outside. Okay, and they are pushed outside and coming in the umbilicus, then it will be called as an umbilical hernia, and in the inguinal canal, then it will be called as an inguinal hernia. If they are coming in that femoral, okay, then we'll be calling it as a femoral hernia. There are various types of hernia, we'll be seeing that further, but let us understand the definition. So abdominal hernia is defined as protrusion of abdominal content, which can be anything, which can be an organ, which can be a tissue, but most commonly what we see in hernia is the small intestine. Small intestine protrudes outside. Okay, so usually the small intestine through a weak point in the muscular wall of the abdomen. So in the muscle of the abdomen, okay, if there can be a weaker point where the muscles become weak enough, at that region this particular abdominal organ or tissue, or which we talk about, especially small intestine, they protrude outside. Protrusion is nothing but it has been pushed. Okay, it is pushing and coming outside. Outside doesn't mean outside of the abdomen, but it is like protrusion. You can see over here, this is a protrusion, this is a protrusion, right? So this is defined as an abdominal hernia. Clear enough? So let us move and understand what can be the causes of this. So we have already seen in the definition, there is a weakness of the abdominal wall, okay, the muscle. So why it is happening? This can be congenital, that is during birth time. There is some problem in the abdominal muscles that can lead into such hernia. Okay, or it is acquired weakness. Okay, acquired weakness, example, commonly seen during aging. As a person ages, okay, the muscles become weak enough, so it is commonly seen after aging, or it can be also seen during some trauma or some road traffic accidents, or because of any injury on the abdominal wall, it can happen. So it is another reason. The first is it can be because of congenital problem. Second, because of any acquired weakness, that is something because of aging or because of any trauma on the abdominal wall. Next is due to, this is the third very important thing, that is increased, okay, increased intra-abdominal pressure. Okay, so when, at what time this abdominal pressure is going to increase? Commonly due to heavy lifting, because when you are lifting something or too much heavy object, what you are doing is you are using your abdominal muscles, right? You are using your other muscles also, hand muscles also, but you are using your abdominal muscles also to lift heavy objects. So what will happen if you're, it is not just once you lift and you get a hernia, no. You are using your muscles, abdominal muscles, for a longer period of time for lifting something which is very heavy objects. That time it can lead into hernia. So that is one of the cause for increase in this intra-abdominal pressure. Okay, the second reason can be obesity, that is a person who is too much obese. Okay, next commonly seen is during pregnancy. Okay, next is straining. Now straining means what? A person is straining a lot during defecation, okay, and too much. It's not just once or twice, he is straining many times. Maybe he is suffering with constipation. Okay, next is coughing. Now coughing is not just once but too much. Next is ascites. Ascites is nothing but collection of fluid in the peritoneal cavity, okay, and or proximity to tumor. If there are chance of any tumor or cancer, then it can lead into hernia. Okay, so the three main etiology for abdominal hernia is, the first one is congenital, the second one is acquired weakness, which is commonly in aging, and the third is there is an increased intra-abdominal pressure. When this pressure is going to increase? When a person is lifting something which is very heavy, pregnancy it can be seen, right? Then obesity or any straining. Okay, understood this etiologies? Next, let us understand the classification or the types of hernia. Now the classification is under two headings. Okay, the first heading is by the site. What do you mean by the site? Where is this hernia located? Okay, we had seen in the definition also inguinal, because it is the small intestine is being pushed into the inguinal canal. Okay, so first one is according to the site. The first one is inguinal, a hernia into the inguinal canal, that is more common. Commonly seen inguinal hernia is among the men's. Okay, this type of hernia, now inguinal hernia, is also further divided into direct and indirect hernia. Okay, inguinal hernia. So we are talking about the classification by the site. The first one is inguinal, and inguinal has two types. And what is inguinal? Nothing but when the hernia is in the, or the protrusion of the organ or the tissue, most commonly we see small intestine, is in the inguinal canal. Okay, and it is divided into direct and indirect. So what is direct? So we'll just understand first indirect one. Indirect one is congenital hernia that occurs when the entrance of the inguinal canal does not close. Ideally, inguinal canal is totally closed in a baby when it is born. But when it is not closed, what will happen? The intestinal or any abdominal organ can come and protrude into the inguinal canal. Then it will be called as an indirect hernia. Okay. So causing a weakness in the abdominal wall. Through this weakened area, the hernia extends down the inguinal canal, and also often it can also herniate into the scrotum or into the labia. Okay, that is it can go in the scrotal region and the labial regions. Okay, so these are the most commonly seen in children. So indirect inguinal can be seen among children because it is congenital, that is when a baby is born, the inguinal canal is not closed. What we see commonly is the direct one. The next one, direct inguinal, is caused by degeneration, okay, of the abdominal muscles, allowing small intestine to pass through the posterior inguinal wall into the groin region. Okay, so this is most commonly seen. I've seen many cases of hernia and the surgeries which are done. We'll be talking about that. But we are commonly seen direct inguinal hernia among men, commonly seen. And here what happens, because of the weakness of the abdominal muscle, which can be related to any of those factors related to increased abdominal, okay, intra-abdominal pressures, which we have seen in the etiology, can be the reason for this direct inguinal hernia. Understood? So what happens over here, that is the small intestine, it passes through the posterior inguinal wall, that is it's pushed into the inguinal canal, and that is why it is called as a direct inguinal hernia. Okay, their indirect one is because the inguinal canal was not closed. Okay, that is congenital. Direct one is directly it is going into the inguinal canal. Okay. Next is, first we have seen the classification by the site. By the site, the first one is if it is going into the inguinal canal, it can be direct or indirect. The second one is femoral. Hernia follows the tract below the inguinal ligament through the femur. If you know your femoral, where we have our femoral arteries and femoral vein, so it follows, just it goes down the inguinal ligament and goes into the femoral canal, then we will be calling it as a femoral hernia. Okay, so the word is very easy, you should remember where it is going into the femoral canal. Okay, next is the umbilical. We have seen in the picture inguinal, femoral and umbilical, if you remember. So here what is happening is intestinal protrusion at the umbilicus. due to failure of the umbilicus orifice to close properly. Okay, the orifice, that is the opening, is not closed properly, then the small intestine or the abdominal organ can go and protrude outside of the umbilicus. Occurs most often in obese women, children, and in patients with increased intra-abdominal pressure from cirrhosis, that is liver cirrhosis, and ascites. Clear enough? So what is umbilical? It's very easy. Now the site, classification by site is very easy. Inguinal is nothing but hernia is in the inguinal canal. Femoral is in the femoral canal. Umbilicus, because the umbilicus orifice is not closed properly, then it can protrude, and commonly seen among obese women, in obese children also. Okay, and where there is an increased intra-abdominal pressure. Okay. Further classification by site, the fourth one is incisional, or which is also called as ventral. Okay, incisional. Intestinal protrusion due to weakness at the abdominal wall may occur after impaired incisional healing due to infection or drainage. That is, incisional means what? There is some incision made at the abdomen, okay, and it is not healed properly. So there are chances that this maybe the organ can protrude out of this incisions. Okay, it's not coming out as such, but it is looking like a protrusion on the incisional area. Okay, so after some incision of after some surgery, if there are chances of hernia also, but here where it is herniating at the incisional region. Understood? Yes, so here is where it is herniating at the incisional region. Next is the parastomal, is also called as peristomal. Okay, peristomal or parastomal hernia. Hernia through the fascial defect around a stoma. What is a stoma? If you remember, we had studied about colostomy. So colostomy is nothing but an opening which is created on the abdomen, so that the colon is brought on the abdomen, and that is called as a stoma. Why it is brought? For the fecal passages. Maybe there is some problem that through rectum the person is not able to pass the stool. That's why we create a colostomy. We also create ileostomy. Okay, so the stoma, that is nothing but the colostomy which is created. Now here what is happening is, around the stoma there can be protrusion. Okay, there can be herniation. Okay, so if you remember, I have taught you about this is the colostomy or the stoma. So around it, what will happen is there can be protrusion of the abdominal organ. Then it will be called as a parastomal or peristomal hernia. Clear enough? So hernia through the fascial defect around a stoma and into the subcutaneous tissue. So where it is herniating, it is around the stoma. This word is very important. Around the stoma. That's why we know the region which is around the stoma is called as a peristomal region, right? Peristomal area. And that's the word, either we call it as a parastomal or we also call it as a peristomal hernia. So around the stoma, if there is something herniating out, something is abdominal organs, maybe small intestine, that will be called as a peristomal hernia. Hope you understood the classification. First is the classification by the site. So by the site we have seen about inguinal, femoral, umbilicus, incisional and parastomal or peristomal hernia. Hope you understood this. Next we move on to the classification by severity. How much severe is this hernia, right? The first one according to severity is reducible. What do you mean by reducible? That is, I can just bring it back, or I can reduce the problem of this protrusion to the normal region. That is called as a reducible. That is, the protruding mass can be placed back into the abdominal cavity. Means I can, without doing any surgery, I can bring this mass or abdominal mass back into the cavity. Then I will be calling it as a reducible one. So if I say whether it is more severe or less severe, it's a less severe one. Okay. The next one is irreducible. Means the word only suggests that I cannot. Okay. So protruding mass cannot be moved back. cannot be moved back into the abdominal cavity or in the abdomen. So this is little bit more severe than the reducible one. Understood? Reducible means what? I can bring back the particular organ into the abdominal cavity. Irreducible cannot bring back into the abdominal cavity. There are further two more classification of the severity, which is nothing but a type of irreducible. Okay. So let us understand that incarcerated. Okay, it is nothing but an irreducible. What was irreducible? That is, the protruding mass cannot be brought back into the abdominal cavity, right? So an irreducible hernia in which the intestinal flow is completely obstructed. What you mean by this is that, as you know, our intestine, what does an intestine? Just consider it as an intestine. So what is the content of the intestine? Intestine contains all those food particles which are almost like a chyme which comes out. It has been further digested, and then in intestine we form the feces, right? So that is called as an intestinal content. The intestinal content is nothing but, here it is completely obstructed. So what will happen is, it will be blocked. So intestinal content, which ideally from the small intestine it goes into the large intestine, and from the large intestine the stool comes out through the rectum and the anus, right? Now here it is blocked. What is blocked? Intestinal content or intestinal flow is blocked. Understood? So what is called as incarcerated. Okay. The next one is strangulated. Now strangulated is an emergency. Okay. Strangulated hernia is an emergency. Why? Because here is not just the intestinal flow or the content which is obstructed, but also the blood supply. So just understand, if the blood supply is also affected to the intestinal region, it can go into ischemia. The bowel or the colon can go into ischemia, that is not getting adequate blood supply. The patient may have severe pain. Okay. So, and again, strangulated is also an irreducible, that is, I cannot bring back into the abdomen. So an irreducible hernia in which, very important, blood and intestinal flow. In the third one, incarcerated, there was only the problem in the intestinal flow, but here the obstruction is not only to the intestinal flow, it is also to the blood. So the blood and the intestinal flow are completely obstructed. Develops when the loop of the intestine in the sac becomes, so when it is completely obstructed, it can happen, the loop means the intestinal lumen. What happens, sometimes this, just consider this as an intestine. So this intestine, hope so you cope up with my diagrams. So this intestine, when they twist, they can twist in this manner. Okay, so when this twist in this manner, you can see twisting is happening. It can happen. Okay, so when they are twisted or swollen and constriction is produced at the neck of the sac. What do you mean constriction? So wherever there is an hernia which is present, for example, we are talking about this inguinal. This is a canal where the small intestine is coming down or protrusion is there. So there can be chance that this small intestine can become constricted. Okay, there's a constriction over here. Okay, shortening of the length is there. So because of this, if there is lack of blood supply, if there is already there is an obstruction of the intestinal flow also. So what is going to happen over here is, it is an emergency condition. We have to treat the patient as early as possible. Emergency surgery will be needed in a strangulated hernia. Hope you are understanding what is happening in hernia. The intestinal, most commonly small intestine, is coming in a particular canal. Okay, or it is going in an inguinal canal, femoral canal, or in the umbilicus. So when it is coming inside, there can be chances that it can get twisted. There can be chances that it can get constricted. Okay, so when it is constricted, again intestinal flow is obstructed. Because of the constriction, there are chances that the blood flow can also be obstructed. So what will happen is, there can be strangulated hernia. Understood? So these are the classification of the types of hernia. So we have seen the classification by the site, and the second was classification by severity. Okay. Next is the pathophysiology. So what is the pathophysiology of hernia? The common is a very simple pathophysiology which I have brought for you. The first one is the etiological factor. So we have seen the many etiological factor which was there, that is causing increase in the abdominal pressure, and because of this increase in the abdominal pressure, there is the abdominal muscles weakens up, or there's a weakness of the abdominal muscle, and that is leading into the protrusion of the organ or the tissue. Which organ? Is the abdominal organ or the tissue, and commonly seen protrusion is the small intestine. Understood the pathophysiology? Yes. Next is the clinical manifestation of abdominal hernia. The first commonly seen is something bulging. Okay, we have seen in the picture the starting also, with something bulging out of the abdomen, right? Bulging over the herniated area appears when the patient stands or straight. Now remember, it happens when a patient is lying down in a supine position, you won't see much of the bulging, but when he stands up, okay, that time what happens is that that particular organ, it comes out. Okay, so bulging commonly seen when the patient is standing, when the patient is straining. So when he is straining during defecation or during something, when he's lifting also, straining at that time, abdominal muscles are required. That time also you can see there is something bulging out. Okay, and this appears when the person is in supine. Even sometimes this bulging can be seen when the patient is having a severe cough. When he's coughing, that time also this bulging can be seen. Okay, but remember, this bulging of the hernia disappears when the patient is lying in a supine position. Hernia tends to increase in size and reoccurs with intra-abdominal pressure. So ideally, this hernia is nothing but the abdominal organ which is lying in that particular region. It can increase, and with the increase of the intra-abdominal pressure. Okay. Strangulated hernia presents with, very important, the strangulated hernia is an emergency condition where the patient will be having pain, a severe pain, vomiting can be there, swelling of the hernial sac. There's wherever that hernia is there, there's the swelling present at that region. Lower abdominal signs of peritoneal irritation and fever. So patient can have irritation at the lower abdominal region, and he can also have fever. Now if this is not treated, the patient can even go in shock. Okay, so it's very important that it has to be diagnosed early and treated with the emergency surgery. Okay. Next is the diagnostic evaluation. How can you diagnose a patient with hernia? Commonly by abdominal X-ray reveals abnormally high level of gas in the bowel. So we can literally see the whitish area which is showing us that there is a hernia present. Next is laboratory studies. Complete blood count, electrolyte level may show heme concentration, which is nothing but increased hematocrit levels, dehydration, that is increased or decreased sodium levels, and elevated WBC count, which is commonly seen in a strangulated hernia, as what is happening is over here the patient is developing fever. Okay. Very important is the management. So how can you manage a patient with hernia? The first management is where we are not using any surgery but a non-surgical treatment. Okay, so which is also called as a mechanical or reducible. For mechanical is only for the reducible hernia. Now what was the meaning of reducible hernia? Reducible hernia means what? I can bring back the abdominal content back into the abdominal cavity. So for those reducible hernia, I can go for the first one, that is a mechanical method. In mechanical method, the first one is using a truss, or you can call it a truce also, a truce or a belt. Okay, now here you can see in the picture this belt which is given. This is applied on the patient so that the content or the small intestine which has been protruding out of the abdomen, okay, in a canal, can be kept at the place itself. Okay, so commonly used is a belt. Okay, so it is an appliance with a pad and belt that is held snugly over a hernia to prevent abdominal content from entering the hernial sac. A truss provides external compression over the defect. So ideally what it is doing is it is pressing that organ so that it should not come into the sac, and should be removed at night, reapplied in the morning before the patient arises. This is a very important point. Now what you mean by this is that, as I told you, that the hernia is prominent, or the bulging of the hernia is prominent when the patient is standing, right? And it disappears when the patient is lying down in the supine position. So what it has been said is that we should tell the patient that apply this belt when he is sleeping on the bed. So before getting up out of the bed, he has to first, in the supine position itself, apply the belt so that the organ already is inside itself. Because once he will stand up, that organ will come into that hernial sac, either in the inguinal canal, femoral canal, or in the umbilicus, right? So it's better that he ties or puts the belt when he is lying in the supine position on his bed. Clear enough? Yes. This non-surgical approach may be used only when the patient is not a surgical candidate. What you mean by this is that some patient will not be preferred for surgery, maybe because of the reason that he is aged 60, 65 years, 70 years old. The physician doesn't want to take him for surgery. Then this procedure will be done for him. That is a belt will be applied. Okay. And very important thing, as it has been said that it has to be applied when he is lying down in a supine position, he has to remove it out at the night before sleeping. Okay. The second method which can be used in a mechanical is a parastomal hernia. In a parastomal hernia, what can be used is, as we know, we are the stoma, that is a colostomy which is there, and we have seen that this parastomal hernia can happen around the stoma. So there is again same like our truss, we have a belt. Now this, what is the difference between the previous belt is, it has a, it has a small opening like thing where the stoma will be lying, and the peristomal region will be having a belt like this. Okay, the same belt is there, but there is a small opening where the stoma can be placed. Okay, so this is commonly used for a parastomal, that is a person who is having a colostomy. Clear enough? So it's often managed with hernia support belt with velcro, which is placed around an ostomy pouching system similar to the truss. Okay. Next is a conservative measure. So what are the conservative other measures which can be taken for this patient? Is no heavy lifting. Very important. He should not lift anything heavy, because that again can strain the abdominal muscle, and with the particular organ can again herniate more, the hernia size can increase. Straining at stool should be avoided. So what can be given to the patient is a laxative, okay, or other measures that will increase the intra-abdominal. What are the other measures which can increase the intra-abdominal pressure? If he is obese, then he should not increase again his more weight. He has to decrease his weight, right, or bring back to the normal weight. So that are the reason for the increase in the intra-abdominal pressure. Okay. Next in the management is the surgical management. Okay, so we have first seen what are the different mechanical methods for reducible hernia. Now surgical management will be always for irreducible hernia, because irreducible I cannot bring back just from outside by applying a belt. I have to undergo a surgery for the patient. Okay, so in the first one is herniorrhaphy, removal of hernial sac and contents. Now here what we are doing is we are removing that particular canal. So either we are removing inguinal canal which is present, and then placing that particular the organ, for example small intestine, back into the region abdominal cavity. Okay, content replaced into the abdomen. Layers of muscles and fascias are sutured back, and most commonly instead of doing an open abdominal surgery, it can be done through an laparoscopic surgeries also. Nowadays physicians are opting for laparoscopic surgeries. Why? Because there is lesser incision, lesser blood loss, and the recovery of the patient is little faster. Okay, so laparoscopic herniography is a possibility and often performed as an outpatient measure also. An outpatient means what? The person is admitted from OPD directly, or not admitted from the OPD, directly taken into the for operation theater, and maybe for 1-2 days, and then he can go back to his house. Okay, so this is herniography, where what we are doing is we are trying to remove that particular canal and bring the abdominal content back into the abdominal cavity. Next is the hernioplasty. Now here the word is plasty, so we are using something in order to push the abdominal content back. So what we are using? We are using a mesh. Okay, what is a mesh? This is a mesh, you can see in the picture. This is a mesh which is also called as mesh plasty, where we are applying this mesh on that particular abdominal or that particular herniated organ, like small intestine which is coming, then we'll place it with a mesh. Okay, involves reinforcement of suturing, often with a mesh for extensive hernia repair. So mesh is been used to bring back the organ at its original region. Okay, so this is a mesh. Next is for strangulated hernia. You know what is a strangulated hernia? Where the blood and the intestinal flow is totally obstructed. So requires a resection of ischemic ball. What do you mean resection? In addition to repair of the hernia, resection means what? We are going to remove out those region of the bowel which is totally ischemic. Ischemic is not, it has not got adequate amount of blood supply, so it is not going to heal back again. So we are going to resect it out and then anastomose the remaining bowel which is there. Okay, and the hernia which is there, that can also be treated back or kept back. We can do a herniography also, and if it is too much, then hernioplasty can be done for the patient. Okay, so the three surgical measures are herniography, hernioplasty, and if there is a strangulated one, the resection of the bowel will be done. Okay. Next is the complication of abdominal hernia. What can be the complication? The first complication is bowel obstruction, as we have seen the strangulated hernia. So bowel obstruction is there, which is, I said, is an emergency, right? The second is reoccurrence. So reoccurrence was the commonest problem in herniography. So what the physician has chosen for the better way is a hernioplasty, where a mesh has been placed so that nothing can come out again. Okay, so recurrence and bowel obstruction is a complication. Let's now understand the nursing management for a patient with abdominal hernia. The first one in nursing management is the nursing assessment. So what we are going to assess? We are going to assess for all the clinical manifestation of the patient. Okay, ask the patient if hernia is enlarging and uncomfortable, that is whether it is causing the patient any pain or whether he is feeling something bulging out. Okay, so that we are going to ask for him. Then reducible, ideally he won't understand reducible and irreducible, but we can identify from an abdominal x-rays or from further sonography, we can understand whether this hernia can be brought back. Okay, and determine relationship to the, this is a very important thing, that when the person is doing some activities or lifting something, did he find it that this hernia which is there, the protrusion which is there is increasing or decreasing, or ideally it will be increasing, and if the mass is further more increasing with activity, that has to be noted down. Clear enough? Next is you are going to assess for the bowel sound. Now bowel sound can get decreased when there is a strangulated hernia. Okay, because the hernia where it is there, the bowel which is obstructed, there can be chances of strangulated hernia, the bowel sound to get decreased. Okay, determine the bowel pattern. Now we need to ask him whether he is able to pass a normal stool or not, because if he is not, then we can understand it is leading into it is leading into this irreducible hernia. Determine if the patient is exhibiting signs and symptoms of strangulation, that is distension, fever, nausea and vomiting, commonly seen in strangulated hernia. What are the nursing diagnosis for a patient with abdominal hernia? The first one you can see, chronic pain related to bulging hernia, which is related to mechanical. Mechanical means what? The reducible hernia if the person is having. The pain can be there with the patient. How can we manage that? The second one is acute pain related to surgical procedure. Now here we are talking about those patients who have undergone a herniorrhaphy and hernioplasty, and then for that patient how can we manage their pains. And the next one is the risk for infection related to emergency procedure for strangulated and incarcerated hernia. This is what I was talking about, where emergency surgery was done, so there can be risk for infection for the patient. So how can we treat that particular patients? So the first nursing intervention for the chronic pain is achieving comfort. So fit the patient. So here we are going to teach the patient about that truss or the belt which is going to be used. Okay. So when hernia is reduced, if order, Trendelenburg's position may reduce pressure on the hernia when, so this Trendelenburg position can be given to the patient so that this hernia can be further going back into the abdominal, the organ can go back into the abdominal cavity. Emphasize to the patient to wear truss under clothing because it's not comfortable for the patient. Body image disturbance can be there when he's wearing it outside. So it's better that he wears inside the clothes which he is going to wear, and apply before getting out of the bed. He should always apply it before getting out of the bed. I told you the reason behind it. Okay, when the hernia is reduced, that is the abdominal content won't be coming out. Okay, when he is in the supine position. Next is very important, so that he should not strain during stool passage. So we can give him laxatives. Evaluate signs and symptoms of hernial incarceration or strangulation. That is nothing but we are going to ask him whether the pain is increasing, whether he is having any nausea, or if he is vomiting, that we can observe for, and fever. So that shows that it is going in strangulation. Insert nasogastric tube for incarcerated hernia of order to relieve intra-abdominal pressure on the herniated sac. So incarcerated, if this there, then what we can do is we can put a nasogastric tube, so the abdominal distension which is there, that can be reduced further, and then it can cause relief of pain for the patient. Next is for acute pain related to surgical procedure. For that, nursing intervention is relieving pain post-operatively. So have the patient splint the incision site with a hand or pillow when cuffing. That is, now this patient has undergone surgery. So we are teaching the patient to hold the pillow or hand when he is cuffing, because that cuffing sensation can cause pain to the patient. That's why. And to lessen the pain and protect the site from increased intra-abdominal pressure, then we need to administer analgesic which has been prescribed by the physician. Teach about the bed rest. Intermittent ice packs can be applied in order to reduce the pain, and scrotal elevation, because since it was related to inguinal, which is almost nearby to the groin region, so there are chances that commonly it is seen the patient develops scrotal swelling. So what we can do is, when there is a swelling, we put a T type of bandage in order to elevate the scrotal region. Okay. So scrotal elevation as a measure to reduce the scrotal edema, swelling which is there in the scrotum, or swelling after repair of an inguinal hernia. So what we are going to do is, we are going to elevate the scrotum with the help of a bandage, so that it is not going to further cause problem to the patient. Encourage ambulation, that is, as soon as possible, it is very necessary that the patient should be ambulated, and advise the patient that difficulty in urinating is common after surgery. This is because the scrotal is totally swelled up. The region nearby of the groin region is having swelling. So there are chances at the starting after the surgery, he may have difficulty in urinating, but it will resolve as the swelling reduces. Okay. Promote elimination to avoid discomfort. And how can we promote it? Most commonly the patient will be kept on a Follis catheter. Okay. Next is preventing infection. As we have seen, there's a risk for infection for an emergency surgery. So what we need to do is check the dressing for drainage. That's a dressing which is present, and the incision site for any redness or swelling. Then monitor for other signs and symptoms of infection, that is fever, any increased WBC counts, chills, malaise, and diaphoresis, that is nothing but sweating. So in order to prevent infection, commonly antibiotics will be given to the patient. That has to be given properly at the time, 3 times it is given. So properly at that particular time, we need to administer our patient antibiotics. Next is the patient education and health maintenance. So what are the patient education and health maintenance which we need to teach our patient is, first is advice that pain and scrotal swelling may be present for 24 to 48 hours, that is 1 or 2 days it will be present, okay, after the repair of an injury. So this is there, scrotal swelling which I told you. So apply ice intermittently, in between ice can be applied. Elevate the scrotum or use a scrotal support, okay, that is with the bandages can be done. Take medication prescribed to relieve the discomfort, that is the pain which is the patient is having. Next is teach to monitor self, that is we should teach him about the risk for infection. So we have to teach him what can be the signs of infection. So fever can be there, pain or drainage from the incision site, that is fear, temperature elevation. Also report continued difficulty. Now ideally, because of the swelling in the groin region, the patient is not able to pass urine properly, but it will resolve as the swelling resolves. But still, if he is having problem in passing urine, then it has to be reported to the physician, okay. Inform that heavy lifting should be avoided for 4 to 6 weeks, that is around 1.5 months. You should not lift any heavy objects. Athletics and extreme of exertion. Athletics are those who always run very fast and doing many activities, right? And extreme of exertion, that is going for a gym and all, okay, so that should be totally avoided for 8 to 12 weeks, which comes around 2 to 3 months, okay. For 2 to 3 months, he or she should totally avoid doing any extreme exertion post-operatively as per the provider's instruction, okay. This is all about our abdominal hernia. So what is abdominal hernia? Is nothing but protrusion of the abdominal content, that is nothing but the organ or the tissue in the either in the inguinal canal, femoral, umbilical, incisional, or around the stoma. And what is common surgery which is done? Herniorrhaphy or hernioplasty. There is a mechanical treatment also where we tell the patient to wear a belt. Hopes you have understood about abdominal hernia. Thank you.